Is competition healthy? Yes, it can be. To slightly misquote Stephen Dorrell, it's very effective when it's used as a rifle shot to deal with specific issues rather than a carpet bombing.
Fantastic. Matt?
Well, I guess my job title requires me to say two things. It depends, and more research is needed. There's been a lot of debate about 3 papers which looked at one particular type of competition reform. They were hugely controversial, but I think regardless of that, we need to remember it was just one context and it was one form of reform. What surprises me is there's very little research on competition between general practices, and that's something that you might think of as being quite a mature market. In my view, the jury's out, and if we want to use it as a policy, we should evaluate it systematically.
Excellent, thank you. Before I ask Victor, when we get to the end of the panel, it'll be open to yourselves. I'll be calling for speakers from the various numbered microphone stands. So if you want to be thinking, if there's anything you want to ask, if nobody wants to ask anything, we're going to have an interesting time. So I'll now turn to Victor.
Yeah, I guess so. I mean, I know for a fact that my organisation has provided services to people under competitive situations and improved those services, and those individuals will be getting a worse service if we hadn't won them. But then I guess I would say that, wouldn't I? Competition, it's all about context, isn't it? There is a case, when I was at Centrepoint, I think we did a study that looked at competition in the homelessness sector, which showed that for every bid, we won 1 in 5 bids, but it cost the public purse to fund us to bid for the 4 that we lost. So there is an issue about whether it's always an effective use of limited resource. But context is everything, isn't it?
And next to John.
Well, I think as an epidemiologist, I would say, compared with what? What's the alternative? You can't say something is healthy or unhealthy unless you've got something to compare it with. And I think we're talking about competition in healthcare here, and the arguments are about whether healthcare is different from other sectors. So I think I've personally had experience, over the years of involving other providers for family planning services, particularly for young people, termination of pregnancy, when there was enormous resistance from the established providers to do that. So at the margins, it can be very important to reorientate, but I think it should be really seen as a sort of last resort. It's the untoward consequences that one has to address here, and I think Victor's already mentioned the increased transaction costs, which can be enormous. The fragmentation. I was talking to somebody this week who has a complicated long-term condition, the sort of thing that we all might finish up with, and was having care from 3 providers who weren't sharing information. A lot of untoward consequences of opening up to competition, which we need to be much more aware of. It's seen as a panacea by people of a certain political tendency.
Thank you so much. And the transatlantic perspective.
Well, thanks. The question, is competition healthy, seems a bit like the question, is sex healthy? And I think the answer there is perhaps, but only between consenting adults in the right setting and with sufficient protection.
Well, if you prepared that earlier, it was brilliant, and if you didn't, it was brilliant. Thank you so much. I'm ready to take questions and feeling slightly spooked that no one's standing up, so please make your way to the microphones. The thing that strikes me, if I can ask David, it seems to me we're being asked to do 2 things at the moment in the health service. One is collaborate and the other is compete. And are those mutually exclusive?
I was going to try a sexual reference then, but I won't.
Please do.
I'm incapable of doing it in the right way.
I think you've just achieved your...
I knew there was a reason I was here. I think it's a bit like the kind of it's top down or bottom up the right thing. You know, it's the American thing.
I think we better move to the microphone.
Can you move on to something? I'm just going to get it wrong. So I agree with whatever you said, David. Yeah.
Right, microphone 1.
Panel, my name's Andrew Mowat. I'm a general practitioner in Lincolnshire. We heard this morning David Pendleton talking about the rock on which the NHS is founded, that free care at the point of delivery funded out of general taxation. Isn't it true that competition is the paper that wraps the rock?
I'm going to take a couple of questions, so I'm going to go for 2. So if we can hold that, if the panel want to signal to me if they'd like to answer one when we get to it. Number 2, please.
We have had example after example of the outcome measure being short-term profit, which is understandable for a commercial organisation, rather than long-term development.
Okay, and thank you, questioners, for keeping your questions brief, and please, I would ask future questioners to do the same. We have a tendency at these conferences to get sermons rather than questions, so those were admirable. Rich, I saw you nodding at that last question. Do you want to? Yeah.
Well, I don't know if I was placed on this panel to come forward with some stereotypical American, the free market fixes everything, because you're not going to get that from me. I think the ability to have a completely free and efficient market in healthcare is absurd. You can't think of it like selling automobiles or toothpaste, because in part a truly efficient market requires that supply match demand. And it's said in healthcare we have infinite demand and very limited supply. It's expensive to train the kind of people to do what we do. But I don't know that it's the paper around the rock necessarily, because there are examples in our country where finance plays out in many different ways with private companies, government spending, and then you have large groups. I mean, one of the problems I have with competition is that what ends up happening is a coalescence of money so that groups get larger. There's a monopolization process that inevitably results from fierce competition, and so we've seen that with health insurance plans, we've seen that even with medical groups. So you have to do this carefully, but there is some evidence in our country that you will create effective behavior change and at times innovation. And you'd like to think that the government regulators that we all have are going to be on top of all of these things and making it work well, but frankly they're not. And so the problem is when you have a centrally planned approach, some bureaucrat gets it wrong and it ripples on forever.
Thank you. David?
Well, I think we have to be straightforward with each other about all of this. And the existing system has not always done great things for all of our patients. We all know that there are areas, for a whole variety of reasons. It could be that the ideas that we have, I mean, the NHS does not have a monopoly of great ideas about things, or that issues and services, and these are very often local services, these are services that affect deprived populations or whatever, that we haven't done the best for our patients in the present arrangements. And it seems to me in those circumstances to test the existing services is the right thing to do. And there are numerous examples around the country, indeed even in Lincolnshire, that show that where we have brought outsiders into trying to solve some of these really intractable problems for us, whether they be services around children's wheelchairs or substance misuse or whatever, a bit of kind of gingering up of the system, a bit more innovation from outside has made a difference for our patients. So we should always use it as a tool to drive change. As I say, I don't advocate the carpet bombing approach here, but I do think that in circumstances we can show that it has made a real difference for our patients and communities.
Great, thanks, Victor.
Well, I think we probably, we'll end up, well, I hope we end up agreeing, because it's not an either-or situation, isn't it? It's not either competition or the devil take the hindmost. I mean, the absence of competition is something else, and it's often a repeated provision of services that actually don't get any better because they don't have to, you know. So it's a kind of, it's not an either-or situation, it's an and. You know, Darwin isn't often quoted in relation to competition, but there's a quote that I've used in the setting up of an institute which is going to look at how we collaborate to deliver better services to the public, and in which he's pointed out that the species that survive tend to be those that collaborate. Never denied that competition was necessary, but collaboration is also necessary. So it's a nuanced argument, and it's not. It doesn't really lend itself to good, bad situations.
Should I chip in?
I'm going to move on because we've got a lot of people. So number 3, please.
Hi, it's very tall, this. Is there a dichotomy between competition being healthy for our patients and competition being healthy for owner-occupier managers, which frames most of primary care in the UK?
Okay, hold that. And 4.
I'm a GP involved with chairing a CCG, and we see competition being used far too widely. We see it in AQP, having several staff devoted to that process, and it's just destabilising some of the work we've done. We see it in PBR, payment by results, causing competition between hospitals. My patients in the practice want good local services. They are less bothered by choice, and although that's helpful for a few, for the majority, the emphasis on competition seems to be far too great. Is there a place for us, this tool being put behind a locked cupboard for those very specialist situations, rather than the mainstream setting where we have to put everything out to European contract, we have to do a lot of other things if things go above certain thresholds?
Okay, thanks very much. John?
Me?
Yeah.
I think we have to ask the question as well, what is the problem that's trying to be solved by embracing competition? You know, I think innovation, change, reorientation, adaptation to different circumstances are clearly part of this. I mean, Barbara Stocking wrote a book 30 years ago looking at case studies of innovation in the NHS, which is well worth having a look at. I think that the issue for me is often the failure of leadership at a political level, at an organisational level, and at a professional level, because it's the leadership that needs to really drive the changes that we need. And we know how large they are, because particularly of the demographic side of things. But to go lurching into wholesale privatisation, I think David's just talked about the carpet bombing approach. I think that's what we've got, the carpet bombing approach. So he must be in a very interesting role of standing alongside the carpet bombers in Richmond House. But, you know, maybe we could find a bit more about that out as we go on this afternoon.
Sounds like a great thriller title, doesn't it? The Carpet Bombers of Richmond House. David, do you want to take that one?
About the carpet bombers of Richmond House, I don't want to say anything about that. It's nice, the world's not like that at all. Well, I do genuinely believe that it should be a tool that we should use. I don't think we should lock it up behind a door. I do think that in the NHS sometimes we've conspired against our patients when we needed to open things up. But I do believe in the view that the way in which we're going to improve services, the way we're going to make ourselves sustainable in the future, the way in which we're going to satisfy the needs of our patients, is by giving people at a local level much more control over what they do and how they do it. So I'm looking for maximising, in a sense, the ability of CCGs to play it as they see it, to look at their population, their health needs, and use whatever tools that they need to do it. Now, part of the issue I think we face is, on the one hand, many of the tools that we have were developed at a time of plenty. So payment by results is a good example of that. Payment by results was developed to increase capacity. You do more, you get more money. That was the basis on which it was. But clearly that is not the case at the moment. So we need to radically look at, and we are already doing with many people, I guess, in this room, about how we can organise that around focusing on outcomes for patients. And I would kind of defend the position of local commissioners and leaders to play, as I say, play it as they sit, as long as they're not conspiring against their local patients.
Thank you. And a health economist perspective, Matt?
Yeah, just to pick up on that point, so I think it's important that the evidence for competition comes from a time of plenty. So that evidence suggests when prices are fixed, then providers can be encouraged to focus on quality. I think it's a shame if we think about competition as only being about profit making. There are other forms of competition, like yardstick competition, where what you do is you encourage people to compete on their reputation. So you regularly publish and you present statistics on quality, and you encourage people to compete that way, not necessarily by tying money to it. And I think there are some really nice examples of where that kind of benchmarking actually leads to improvements in quality and changes in patient health. What I think that the danger is, in some ways, using that sort of competitive force to get people to focus on quality and not allowing people to compete on price.
Really interesting. Thanks. Okay, number one, please.
What worries me about the discussion around competition is that a lot of the good news messages about the NHS seem to have been almost sort of suppressed beyond belief, in the sense that the British Commonwealth Association voted the UK's NHS the most cost-effective healthcare system in the world. And then across the water in the United States, excuse to the gentleman over there, but we have a healthcare system that is the most expensive in the world, with poorer results across all the entire spectrum of disease, from cancer to chronic disease management, than countries which are spending half as much. And as much as socialism and communism failed to produce a good car, competition and the free market has failed to produce a good system of healthcare. And if we look across the world at countries...
Can you make sure there's a question at the end of this sentence?
Yes. The question is that healthcare should be backed by government and funded by government, by taxpayers, and that the private enterprise has no place or role to play in the provision of healthcare. And the experiments across the world that have been done, looking at countries like Brazil and Turkey and Cuba, which have managed to achieve enormous success in managing healthcare in an equitable way, have all done it through government-backed socialist systems.
I didn't actually hear the question mark, but never mind. Point well made. Tim, number 6, please.
A short question.
Thank you.
Tim Ballard, I'm the College Sustainability Lead. Should competition be seen as an asset or a liability in relation to the NHS carbon reduction strategy?
Ooh, right. Where shall I give that? John.
I didn't quite catch the question. Could you say it again for me?
Yeah. Tim, do you want to repeat?
Should competition be seen as an asset or a liability in relation to the NHS's carbon reduction strategy?
Oh, the carbon reduction strategy. I thought you were talking about harm reduction, and I was going off on a different tack. Well, it's been half-cocked, hasn't it? I mean, you know, from time to time we hear mention of carbon reduction and greening the NHS, and the NHS is a massive generator of global warming. So I think, you know, I would say that's back to leadership. I just wanted to just pick up on this point. You have to remind yourself that, you know, there's no quality without population coverage. In the United States, 40 million people don't have coverage. So however good clinical care is in parts of America, that is not a quality situation. We start from a different position. We start from a position where everybody has access. And the challenge for us is to improve quality. The challenge for the Americans is to try and ensure that every American has access to healthcare, and they fail dismally at that. But we have allowed ourselves to be infatuated with that model. And we had been doing quite well, really. The big problem is that we've got to get resources out of hospital into the community, and we've got to develop a decent public health service. Now, I think Duncan Selby, is set about the job very well for Public Health England, but the fragmentation now, if you look at the map of functions for public health, it is just absolute nonsense. I mean, it is unbelievable duplication and fragmentation. So the big problem that we're all going to face over the next 5 to 10 years is to bring coherence to a dog's breakfast, which is not an easy task.
Rich, do you want to pick up on these various American comments?
Well, a couple things. I think one thing that's not well understood about the U.S. is that if you present for care at any hospital, you'll be taken care of. Nobody does what's called a wallet biopsy. It just doesn't happen. In fact, there are federal laws that prohibit it. But the problem is, as John rightly pointed out, is that we have about 40 million without adequate health insurance coverage, which is a bit of a different issue. What that means is that people tend to show up late in their stage of disease when they can't deny the symptoms any longer or are too afraid. And what ends up being, in the primary care setting, a relatively small and easy to manage problem is now blown up into something big. I think one of the challenges you have, though, in giving all of this to government is that governments change. And so you look at the Netherlands, which moved from a completely public system to a private system, and whether you like it or not, you're having to adjust to those changes. And in a flash of an election, you may have another NHS change. I mean, you guys are changing the NHS about every 15 minutes, it looks like to me, from the outside. And the irony in my system, as chaotic and fragmented, as incoherent as it is the daily practice has not changed terribly much, because out of this chaos comes sort of a consistency between clinician and patient. And if I might, the final concern that I have about paying for performance or results, which we've been doing for quite a while in the States in various ways, is that generally the results that we're aiming at are profession-derived. They aren't patient-centered. Patients don't care about their hemoglobin A1C. I mean, we make them anxious about it, but they don't really care about it. They care about dying. They care about pain. They care about disability. And those are the things I think you really want to measure in a meaningful way. But this will take you down a path where eventually the data become public, and then you're going to be doing graduate school courses on how to help the public interpret the data.
Okay, thank you very much indeed. Number 2, please.
Anthony Tutor, Chair of the Patient Partnership Group at the RCGP. My question is really about patients, and hand in hand with competition is choice. And do the panel think that we're being honest with the British public? Is there really choice with competition? And what are the negatives, and what are the answers to those negatives?
David Nicholson.
All right, sorry. Well, are we being honest? Well, what we know is that some patients at some stage of their treatment are given choices, and large numbers of them are choosing different alternatives to what they had done in the past. So it is happening and having an effect, a real effect across the system as a whole. Choice in itself is not an end. Choice is a part of, in a sense, giving patients more control over their care and the services that they aim. So as an aspiration, I think it's a really important thing for us to take on board, to think about, and to help and support our patients to make happen. And it's up to organisations then to deal with the consequences of those choices when they make them. But if they're making them to increase their control, we know that lots of evidence shows us that when they make those kinds of choices, they tend to choose the least interventional or less interventional way of having their condition dealt with. They tend to use less resource than they would normally, and they have better outcomes. So it seems to me, in those circumstances, choice not only needs to be a reality, but we need to kind of develop it. But again, in itself, it won't solve anything.
I've never known a panel who are better skilled at avoiding eye contact with me, so I'm having to sort of read your body language as to whether I think you want to say anything. And Victor looked pensive, so I think he wants to say.
It's natural, really.
It's just natural pensiveness.
I was born pensive, I should say. Can I just say something while you've
Please,
mentioned, I mean, I'm always pensing in front of doctors, but anyway, this is a good, the thing is, the conversation is going to get boring if we just think about competition in terms of the private sector and the public sector and devils and angels. I mean, really, we've kind of moved on, haven't we, a bit? I mean, my organisation does not distribute profit to dividend. We don't have dividend shareholders. I mean, let's be clear about that. And I think, really, the issue is about how do we maintain the money that's available, which is limited, as far as possible in the public provision of health and social care services. That's the issue for me, not really about whether, and it would be nice if we just could hear a bit more about the fact that we're spending 3.39 billion at the moment in delivery of health and social care services in the not-for-profit sector, some of which is won through competition. I think, and we're going to be spending more in that sector if we're going to deliver integrated services in communities, by communities, and I think we just need to kind of move on a bit.
That's very helpful indeed, very helpful. 3, please.
There's lots of talk about the fact that competition in theory is a good idea, but Victor, your organisation might not have to give dividends and have shareholders, but many of the organisations that the NHS will interact with do. Do today's commissioners have the skills, learning from the early days of PFI, to negotiate practicably, sensibly with these organisations so that the NHS doesn't lose out financially?
Who wants to take that? Matt, I think.
Well, they don't, do they? I mean,
John?
Very few do. I mean, I'm fortunate. I've been working in Cumbria where we've got some GPs with an appetite for this, and they've been doing quite well. But when they started, when Mr. Lansley came up with his, half-baked ideas, I gave Cumbria a 70% chance of pulling it off. I think they might be about to pull it off. But, I mean, around the country, most people here presumably went into medicine because they wanted to practice medicine. There are very few people who want to spend most of their time involved in commissioning, and we're going to have to recreate PCTs or something to have the critical expertise. It's a madness, but I think Victor's point's very important, because I think if we think about alternatives to existing provision rather than competition, then and we think about what he was saying is that the investment in communitarian activity and NGOs in voluntary organisations and so on, going much wider than the big ones, because a lot of the big ones are now become indistinguishable from public sector organisations. But ordinary community associations, small scale things at neighbourhood level and so on, then there's a leverage here of leveraging out assets of communities, which can really help us, particularly in hard times, but actually it's desirable in good times too. I think the choice thing, that David talked a bit about, there's different types of choice and levels of choice. I mean, I'm struck, because I spend a lot of my time in a village environment at the moment, where people come in the pub and everybody discusses their medical condition. It's a sort of common currency. It's not a sort of middle-class bourgeois thing where you keep it to yourself. You discuss somebody's prostate cancer around the bar, and it's from one end of the bar to the other. And what they tend to say in an agricultural community is they don't want choice. They want the doctor to tell them what to do. This was novel to me, but it's actually a reality. So we have to be a bit careful about being naive about the whole issue of choice, because I think it's quite a middle-class concept. And we need to see, I mean, on the education front, I mean, I defy anybody who's got to make the choice now about what to do with their children when they get to 11 to understand what the choice of schools is. And most people, if you ask them, just want a good school nearby. And I think it's the same with health services.
Matt?
Yeah, I just thought it was... I thought it was worth responding on this idea that competition is theoretically a good idea. I mean, any economist who's kind of worth their salt would not agree with that. So theoretically, economists are very equivocal about competition. Any economist who's looked at health would say this is an area in which you would not expect competition to work. It's not an area where most consumers are particularly informed, although there are exceptions to that. It's not an area where there are many providers, though there are exceptions to that. And it's not something about which we can measure the key things that we value about the service. So we all agree that the quality, the output of the service is what's key to us, and we struggle to measure most of that. So most economists, I think, would look at this and say this is an area in which you would not expect to be suggesting competition. The Office of Health Economics really helpfully did a nice review looking at services, saying these are the kind of things that you might want to look at when you're thinking about introducing competition, and they went through a variety of services. And in no service did they come up with a kind of unequivocal, this is an area in which you would expect competition to work unequivocally. So I guess, again, it's inevitably I'm reverting to type, but I think we need to be incredibly cautious, and we need to evaluate as we go along, because there is no theoretical basis for saying competition is the right thing to do.
Okay. Number 4, I believe.
Martin Wilkinson, West Midlands. Looking globally at other health care systems, where there is competition between primary and secondary care often wins. They've got more power politically and have more money. Where there's patient choice, and we've seen this in the UK, patients often miss out primary care and go directly to A&E. And in other countries, again, it leads to a weakening of the primary care services. Well, if we look at other countries that are largely private health based, it's associated with weak primary care. So I'd like to ask the panel what safeguards we can put in place, safeguards we can put in place to prevent competition and patient choice leading to the detriment of primary care and ultimately the NHS.
Okay, very interesting. Rich Roberts. Yeah.
Well, one of the things I think we confuse when we talk about competition healthcare are different tasks or goals that we're trying to achieve. Many times, at least when I speak to policymakers, they want to be reassured that the professions are accountable and that the dollars are being well spent. There are ways to do that that have nothing to do with competition, but as was said earlier, it's often a failure of leadership or political backbone or some of the other things that make this hard. Doesn't mean it shouldn't be done, but I think it confuses the picture. The other thing I would say in terms of secondary care often wins, I see this every country I go to. You can be in the poorest part of Nairobi and you still want to get to the hospital, even if you've got a family doctor close by, just because that's sort of the cultural belief. And in my country, it's the same thing. We're constantly trying to do this. And so I think in the end, what we've got to do a much better job of in primary care is delivering the goods, being accessible, being transparent and accountable, and communicating our message effectively to the public. In fact, one of the things I would urge GPs to do in every one of your communities is you have the most powerful advocacy group in your country. It's called your patient panel. And don't be afraid of them, don't keep them at arm's length, bring them into these issues and problems and get them involved. They'll help us find a way.
We've got so many questions and so little time. Unless the panel are waving at me desperately to speak, I'm going to move on to number 1.
Thank you. If we accept that competition can be used like a bullet to improve a service, then in this week of the West Coast Line franchise fiasco, can we trust our regulators to set up and judge competitive bids fairly? And if the answer is no, what should we do?
I guess that's probably a Matt, health economist question.
Well, there's a lot of GPs being lined up to be blamed when this lot doesn't work.
But I think the issue about the trains running on the West Coast Main Line is not an issue for a health economist.
Very smart.
I thought that would come up.
But David, do you want to pick that one up? No, I can see that.
No, I'm happy to drone on about railways. I use the West Coast Main Line all the time. And I think it comes back a bit to the point that was made earlier on about our ability to procure, our ability to negotiate, all of that sort of thing. And if we're creating a system where general practitioners feel it's their job to do all of that, I think we've got a massive problem. We need to create the right kind of people with the right skills that we're trying to do at the moment through commissioning support organisation, all the rest of it, to enable people not to have to go through all of that process themselves, but to focus their attention on the clinical decision making that's required. My advice to anyone I've been involved in the last 5 or 6 years with the National Programme for IT, and I've got as they say, the scars on my back around all of that, and that is that big, high-profile, politically driven objectives and changes like this almost always end in misery and failure. So getting ourselves, perhaps I'm an optimist by nature, as being an health service manager for the last 35 years, I kind of would make me like that. But I do, and I take absolutely the criticism of the Healthcare Act and all Health Social Care Act, all of that sort of stuff. What it does do, though, it does change the nature of the relationship between government and the NHS in I think a really profound way. But we can conspire to stop it if we want, if we want to. We've now got an NHS commissioning board. We've got clinical commissioning groups whose responsibilities are actually in law. They're statutory bodies with a legal framework. No longer is the NHS what the Secretary of State said it would be. That's not what it is. It's absolutely, enshrined in legislation. And it creates much more difficulty for politicians to arbitrarily get involved in the day-to-day operations of the NHS. Now, we can take that as a profession, as an NHS, and take it where we want it to go, or we can conspire with people to pretend it hasn't happened and that actually we need to go back to the politicians to ask for guidance on absolutely everything. And I think it's a really important issue for us as we go forward to get hold of this opportunity and make it work for the NHS and patients.
Thanks. I'm trying to choose, get people out of the waiting room in the order that they arrived. And at the moment, I'm going to go 6, 2, 3, 4, 1. It's very unlikely that I'll get round everybody. We've only got about 7 minutes to go. So it's 6 next, please. 6.
Because of inefficiencies with monopoly supply and lack of innovation, markets are introduced, but we know that this complete market failure in health has been originally alluded to with lack of problems with market failure. As a result, it suggests that health needs a third way that's neither monopoly supply nor market dependent. Whilst health is very much a political issue, with politicians running off a 3-year planning cycle, whereas health often needs a 10-year planning cycle, whilst it's still a political issue, will that third way ever be found?
They're all nodding. John, you're nodding.
Well, I think it comes back to what David just said. You see, I don't think anyone's told the public that their members of parliament are no longer responsible for what goes on. I think that the public will still expect their MPs to be able to influence what goes on, and they'll be turning up on Saturday mornings at the MPs' surgeries and giving them hell. And the things will still be debated in the House of Commons. I think it's just, it's naive to think that this institution, the public will accept this mechanistic device that's been passed through the House of Commons will somehow change things. It won't. The public expect their MP to take up their interests about the NHS.
Right, yeah, but the question is what do we do about it? And of course the public will expect their MP to take up their requests, and there's no avoidance of the Secretary of State's responsibility for the outcome. But we do have a commissioning board, we do have CCGs, we do have GPs, and there is a question as to what do we do now. And I'm an optimist, partly because I'm paid too much to be a pessimist, and the people outside this room expect us to do something with what we've got. And it strikes me that one of the things that we're going to have to do is look at, I don't agree, by the way, with the woman who said that, most of the services are going to the private sector who do dividend. Actually, the people that are the sharp end of the inverse care law that are really suffering are coming to organisations like ours and organisations like yours, and it's how we work together to provide a health and social care service that actually provides a service to those people and saves money that's going to, in my view, dictate the future of the health service. And I think there is a big question about what we do now, because it's not going to go backwards. We can't go backwards. We can only go forwards. And I think the public have quite an understandable expectation that that's what we do.
Rich Roberts?
Well, I'm not sure I'm in a position to advise the NHS what to do, but I can maybe give some advice on perhaps what not to do. In my country in the 90s, we tried some kind of an in-between approach between a public utility and a free market approach. We called it managed competition. It was the first time in the last 40 years that our cost curve actually flattened, because most of the care was moving into primary care, as it should. But there were instances, individual, though thankfully rare examples, of really stupid things that health plans did, making the inner city child take 4 different buses to the emergency department that they'd been contracted with, and he died en route in status asthmaticus. Really absurd things. I think at the end of the day, what you really want to do is make sure that your health system reflects your values. You look at Canada. They take great pride in the Canada Health Act because for them it's a matter of equity, it's a matter of social cohesion. We have, to I think our everlasting sadness in the United States, never really had that kind of a national dialogue around health care. We've come close a couple times, but we really haven't. And I'm going to keep working at it, but that would be my advice to you.
Good, very good advice.
I can't remember where I got to, but I think it might be 2. Yes, it's 2.
Tony Kendrick from Yorkshire. I'm an academic GP and I've been involved in writing the Academic Health Science Network bid for Yorkshire and the Humber. And it's coming back to the point that David mentioned at the beginning, that we seem to be encouraged to be collaborative in some ways and competitive in others. So I'm optimistic as an academic that AHSNs might make a difference, but if they do, they'll do it because providers across the region and commissioners across the region are working together to develop new care pathways, to rationalise tertiary services, to do more for less, which is what Sir David wants the NHS to do. How's that going to be squared with what I believe is still in the Health and Social Care Bill, which is an imperative that Monitor ensures there is competition between providers, because if providers and commissioners are going to get together and try and produce a rational system that's informed by evidence through the academics, can that be just torpedoed by the regulator?
I'm going to give that one to David Nicholson while he's thinking. I'm going to take number 3 after that, and then we're done. I know we're very slightly overrunning because lunch took longer than we expected. So David on that one, and then number 3.
Okay, I mean, the whole issue about academic health science networks, that some of you may know a lot about and some of you may not know, are about developing relationships and partnerships to speed up innovation and change within localities. We asked people to come together and put forward proposals, and we've got 17 covering the whole country. So just asking the question, it wasn't you weren't forced to do it. It wasn't a kind of guidance that you had, but people have come together in order to put forward their proposals to become academic health science networks, which I think is fantastic and shows the kind of values and the way in which people want to work together. And in a sense, it's a kind of countervailing force to some of the other fragmentation issues that are going around. But I think a really constructive tension we can get there to make it work. I mean, the interesting thing about Monitor, and this is not all finally resolved because the details of the way Monitor is going to work are going to be established in the new year with the regulations as they are set. But the principle at the moment, as you remember the debate when it started, it was Monitor were about promoting competition. In fact, that got changed. And we ended up with a place where Monitor were responsible for investigating and putting right abuse. So that's a very different set of arrangements, and you can see in the way Monitor are trying to think about themselves, it's made them think very carefully. They've also got a responsibility or a statutory duty now of partnership, to collaborate together. And I think in all the kind of political furore and all the carrying on that was going on, Health and Social Care Act, those really important things were actually put in place, which I think strengthen the position as we go forward. Victor will know more about this because he was hopping up and down voting for and against it, as I remember.
But he's not going to have a chance to tell us. Number 3, very quickly.
Very quickly, Scott Brown, Chairman of Northern Ireland Council and NHS GP. A quick comment and a quick question. Admired Professor Ashton's comment about doctors not training to be businessmen and women. Of course, he didn't finish the statement, and that is that what they did expect, however, was to have reasonable premises and adequate staff to do the job and to indeed to develop it over the next 30 years. My question is this: what country in Europe, given this is a conference on global general practice, what country in Europe outside of the NHS would panel members like to fall sick in and have their continuing general practice delivered? Is there much competition there, and how does that government fund it compared to the NHS?
Because of time, I'm going to allow the panel to only answer the first part of your question, which is to name the country. Rich?
I can't speak for, English citizens or British citizens that go to other countries. I think from my vantage point, it would probably, if I were an American, it would probably be the Netherlands or Denmark.
John?
Always go to Finland. They've had, a health system built on primary care for over 40 years, and it's well worth going and having a look and seeing how they do it.
Victor?
Okay, I've never been ill anywhere else, actually. Yeah. I like Blighty, me. But I was going to say Nigeria, but that'd be a lie. I guess.
Largely on the grounds of not being in Europe, I guess. But there we go.
Yeah, at the moment.
Not yet.
They're thinking about
that's
it.
True.
I don't know. I mean,
Matt?
UK is okay.
I'll go for Norway, just to stick with the theme of the session. So, Norway, they had their reform to make competition between GPs a little more easy, and that resulted in GPs being more generous with their time, more generous with their tests, more generous with their referrals. So.
And David, and if you say Scotland, it'll make headlines in the HSJ. So
Scotland, because the amount of money per head of population that they get.
Okay. I would very, very much like to, on behalf of all of you, to thank our panel, David, Matt, Victor, John and Rich. Okay, if you could now make your way to the next set of concurrent sessions, TLB in the exhibition halls from 4.